It really is a humbling experience, and I'm very, very careful to be honest about what I know and what I don't know. Now, I love this quote from Daniel Patrick Moynihan, who was a great senator from New York. He says, "Everyone's entitled to his own opinion, but not his own facts." One of the real challenges in this pandemic has been there's been so much misinformation and information that changes over time, which really confuses the average person in our community. Now, Dr. Zhang is probably a name that many of you may not know, but he was the hero of the original SARS outbreak in China. And this is one of his quotes. "In science, it is only right to seek truth from facts. Otherwise, patients will be the victims." And boy, he really hit the nail on the head. Now, when we started with this pandemic, it was not a pandemic in February of 2020, but we had an enormous knowledge gap in what we knew about SARS-CoV-2, or what you know is COVID-19. We initially thought perhaps it would be like the original SARS virus, but it turned out to be extremely different, and I'll explain that as we go along. Our knowledge gap has rapidly decreased, but you can see there's still a ways to go. There's still things that we need to understand and we need to explore, but we're in much better shape now, almost 1 year later, in our knowledge and some of the things we're going to discuss tonight. Now, what have we learned? The first thing we learned, which was a real game changer, was that 30 to 40% of COVID infections are asymptomatic. This was very different from SARS. In SARS, you did not have any virus that you could transmit until you developed symptoms. There wasn't a big pool of people that were asymptomatic. That's really, really different. On the good front, about 80 to 85% of those people who develop symptoms have very mild cases, very similar to a flu-like illness, and doesn't require hospitalization. Again, another challenge that we've learned from this infection is that virus can be in reasonably high quantities 24 to 48 hours before symptoms start, which is, again, another one of the challenges in trying to understand transmission of this virus. There's a growing body of evidence that suggests, despite a lot of other possibilities, that the primary way this virus is transmitted is by close contact with droplets and occasionally through aerosol, usually within 6 feet. It occasionally can hover in the air for extended periods of time, but usually that's in closed, crowded spaces with poor ventilation. We know that masking and social distancing works. Masks can substantially reduce the risk of infection, mainly, as I'll show you a little bit later, through controlling droplets from the source, but it also has been shown that it may actually provide some protection for the person who wears the mask as well, lowering the amount of virus exposure. I put in bold red that transmission is related to behavior. Now, many of us have gotten COVID fatigue. There were lots of small gatherings that occurred over the holidays, which in large part has driven the increased number of cases that we've seen in our community. Now, this next bullet, really, I feel passionately about this, that the media tries to make truth by creating fear and moral bullying. What we need, ladies and gentlemen, is consistent messaging based on science, not based on fear or politics. We need to foster public trust. It's especially true because we know, as that last bullet indicates, that in fact we know that the vaccines are safe and effective, but yet there's still some pushbacks, and I'll give you the data on percentages in just a moment. Now, here's an example of what I mean by bullying and hyperbole. This is from one of our local experts, I'm sorry to say. It was in the Houston Chronicle this past Sunday. This is his comments. He said, "We have failed on everything." Well, that really engenders confidence, doesn't it? The first thing you say is we fail in diagnostic testing. Now, there's some truth to this. In fact, the initial test kits that were sent out by the CDC were contaminated, and it set our testing back at least a month. But on the positive side, through working with the FDA, reducing some regulatory requirements, we have now developed multiple platforms for diagnostic testing. And when we didn't have enough testing in the beginning, especially in a city like Houston, we have multiple test sites, multiple opportunities to get testing with very good turnaround time. He also said we failed on genomic sequencing. I'll explain what we mean by that when I talk about this new variant. But again, that's partially true. The UK does about 40% of the genomic sequencing for new emerging infectious diseases. We do less than 10%. That is a problem, and I think we need to correct that problem. The next bullet he said is we failed to halt the entry of the virus from Europe. I'm a little bit confused. How in the world, with global travel, with asymptomatic disease, how are we supposed to halt all virus entry from Europe or any place else in the world? I don't get that. The last thing, we failed to halt the southern surge. That's the surge that we all felt in July. Again, I'm not exactly sure what he means by that and how we could have halted it. We certainly could have blunted that had we had masking and social distancing, more people doing that. And then he says, we have failed now to halt the fall surge. And we say we, I already mentioned that a lot of the transmission that's ongoing now has to do with human behavior. So I'm not exactly sure all of these we failed statements are correct. Now, you've all seen slides like this about flattening the curve, where we went into, in April, we went into stay in place orders. And the whole idea of that was to actually flatten the curve so that we didn't overwhelm the healthcare system capacity. And in April, before we understood much about this virus, that was the only tool we had in our toolbox. And it did help blunt the curve. It did help protect our health system capacity. But what it also did, and this is why some of these lockdowns have not been totally successful, we may temporarily suppress the number of cases, but the cases will occur over a longer period of time. So it hasn't been exactly the answer. Now, I want to try to put this current pandemic in perspective, and I really especially want to compare that to the 1918 pandemic, which I know all of you have heard about, the so-called Spanish flu. So let's look at some numbers. There were about 50 million deaths due to H1N1, and this was a population that was much smaller than what it is now. Now, I want to compare that. We'll go to the right-hand side. We've had almost 2 million deaths nationwide. That is horrible. That is tragic. I'm not minimizing the numbers. And there were over 500 million cases of H1N1. That's pretty staggering. And so we're up to about 93 million cases worldwide now. Now in the US, we had over 600,000 deaths. Some people think it's around 650,000 deaths. Again, you can see our population was 1/3 of what it is now. And again, if you look at the number of deaths in the US, again, tragically, we've had 93 million cases worldwide, and we have a population of about 327 million. But what some people don't tell you, because we're up to 386,000 deaths now in the United States, we'll probably be well over 400,000 before this wave is over, unfortunately. But what they haven't told you, whoops, sorry about that, is in fact, there's been 51 million people worldwide who have recovered and over 10 million people that have recovered here in the United States. So the flip side of the equation. Now, I want to make mention a little bit to the last pandemic, which was H1N1 in 2009. Look at the number of cases that were infected during 2009, almost 61 million cases. That's an enormous number of cases. We got lucky because this turned out to be a pretty wimpy virus. And so the mortality was extremely low. And unfortunately, we didn't learn all the lessons around our public health deficiencies. Now, let me just kind of draw your attention to what's happened in the last, let's say 2 decades. SARS came about in 2002, MERS in 2012. The COVID that we have now is 2019. The reservoir for this, that many of you know, are bats. For SARS, the intermediate was the mammal called the civet. Never heard of the civet before all of this. It turns out the camel is the intermediary for MERS. And by the way, MERS is still endemic in the Middle East. And now we have COVID. We don't know what the mammal intermediary is for COVID yet. And you can see that about every 7 to 10 years, a new emerging serious infectious disease is coming about. And you might say, well, why is that? Why are we seeing so many new emerging infectious diseases? And I think this has to do with growing exposure. And if you look at this particular graph, and you look at the percentage of the population now living in urban areas, people are gravitating to more urban areas versus rural areas. If you remember the Ebola outbreak from years ago, the Ebola used to be in these very rural African communities, and all you basically did was isolate them. And usually it kind of burned itself out and didn't get into the larger cities. That, of course, changed with the Ebola outbreak, with people getting into the cities much more widespread. And then, as you know, with global travel, we had some cases around the world. The other thing I've noticed is, of course, that the population in China in urban areas has gone up significantly. But look at just airline passengers between the United States and China, and look at that all over the world. You want to know why it's so difficult to contain new emerging diseases? Is because before we can detect them, they're already spreading globally because of global travel. The other thing that's become apparent, I mentioned in 2009 with the H1N1 pandemic, we didn't learn a lot. If you look at funding for US states and local health departments, the public health is the backbone of really community safety. And if you look at from fiscal year 2003, and you take that to now, the present, and you allow for inflation, there's been a significant decrease, and yet there's increasing needs for all these emerging infectious diseases, but we're actually spending less. And if you look at hospital preparedness, that's pretty dismal. And you can see that play out in multiple areas of the world, including some areas in the United States where they've been overwhelmed, and our hospital preparedness just wasn't there. Now, with that sort of as a background, I just want to just remind you what this virus looks like. The thing that everybody always remembers, they've already heard about the spike protein. Well, those are these things that stick out from the virus. This is an RNA virus, sticks out from the virus. And this is going to become a very important point when we start talking about how it gets into the body and how the vaccines actually work. So what do we know about transmission? The mean incubation period is about 5 days. And the range is usually 2 to 14 days is the big range. Almost everybody who's developed symptoms will develop symptoms by day 11 or 12. And that's why the CDC has this quarantine period, which has just been modified to be 7 days with testing and 10 days without testing. But remember what I said before, you begin to shed virus in enough quantity that you could transmit this virus several days before you develop symptoms. So let's say you develop symptom on day 5, that means on day 3 and beyond, you could be inadvertently spreading this to others, which is why this asymptomatic part of the equation is so important for universal masking. Now, the other term I want to introduce to you that you've probably heard, which is the reason I'm going to go through it, is something called the reproductive number. And that basically measures how many secondary cases results from a primary case. And to give you some perspective, SARS-CoV-2 or COVID, the reproductive number, depending upon which strain is circulating, we'll come back and talk about the new variant in just a moment, is anywhere from 2.5 to 3.5. I want to compare that to the usual seasonal flu. It's about 1.8. So this virus is more contagious than the typical seasonal flu. But I want to compare that to another common virus, which unfortunately has reemerged in some areas in our country, measles. because our vaccination rates have kind of come down some. And you can see the reproductive number for measles, it's a very highly contagious virus, is 12 to 18. Chickenpox or varicella is around 10 to 12. So these are much more contagious virus, and they're spread by the airborne route. Now, you'll see why the reproductive number is very, very important when we start talking about herd immunity. Again, a term that you've all heard before. So how does the reproductive number work? And this is just a nice schematic representation. So here's the index case. That person will transmit it to 2 people if the reproductive number is 2. That person will then transmit it to 2 other people, and you can see how this can amplify transmission in the community. Now, if the reproductive number was larger, you can see how many more people can be infected very quickly. We like to get the reproductive number down to less than 1. Remember, naturally for SARS, it's probably 2.5, and in some situations as high as 3.5. But we want to get that reproductive number less than 1, which means that we have control of spread in our community. Now, how does that reproductive matter in terms of herd immunity? Herd immunity basically is a number of people in our community who are immune to the virus, or in some cases the bacteria. If it's above a certain level, transmission will not propagate in our community. So as an example, for a highly contagious virus like measles here with a high reproductive number, we need essentially close to 95% herd immunity. That's why when the vaccination rate started to go down because of states allowing for exemption in our children, a measles virus being introduced into community can really take hold and cause an outbreak. That's what happened in Disneyland, if you remember, years and years ago. Now, if you look at SARS-CoV-2 down here in red with that 2.5 to 3.5, again, it's closer to around 70 to 75%. But if this new variant were to take hold and would be more contagious, the reproductive number could be closer to 3.5. That means herd immunity may need to be higher in the range of potentially 80 to 85%. So understand, more contagious, higher reproductive number, you need higher number of people in our community immune to the virus or the bacteria in order to stop its spread. So what do we mean by close contact? That's another thing that people always ask me, you know, how do I know that I need to quarantine? I've already mentioned the 6-foot rule, but there's also a time limit. If you just casually pass somebody in the hall not wearing masks, that's not considered close contact. You need 15 minutes or more within 6 feet without wearing masks in order for the virus to be transmitted if one person has virus in their nose or in their throat. Now, if you provide care for someone at home who's infected, that's a household contact. That's one of the higher risks for secondary infections. If you have direct personal contact, you know, we always like to hug and kiss. That's part of our culture. You know, we've had to elbow bump, and we can't hug and kiss our grandchildren. I know for some of us, it's been really, really hard. You don't want to share eating utensils. And of course, if someone sneezes or coughs and puts those respiratory droplets directly on you, that's another way in which this virus can be transmitted. Again, most people that are asymptomatic, it's going to be that first bullet. Now, I want to emphasize something, and I'll emphasize it multiple times. Being outside does not give you a pass. Let me say that again. Being outside doesn't give you a pass. If you cannot maintain social distancing, then you still need to wear a mask. And I've seen little gatherings, oh, we're going to have it outside, and they're outside together for an hour or more, close contact within that 6 feet space. And because they think they're outdoors, that the risk of transmission won't occur if someone is asymptomatic. I can tell you that's been proven over and over to be incorrect. So please, if you cannot social distance, even if you're outside, please wear a mask. Now, I think it's fair to say that we are in the 3rd wave, and this is a pretty tough time, but I think there's a little bit of hope based on the new data that's emerged this week, and I hope that it holds. So here's Memorial Hermann Health System. Okay, this was the big spike in July, which was really very devastating really stressed our healthcare system, but we held and we came together. But as of today, we're up at about 875. We were about 1,000 to give you some perspective. And this number has been stable now at around that 875 mark now for about 3 days. So I really hope that holds, but we're going to have to see what the next week has to say. And if you look at our Texas Medical Center dashboard, you're going to see some numbers. Remember I talked about that reproductive number? Well, so far this week, it's at 1.09, so it's getting closer and closer to that 1 number. And back in September and October, by the way, it was less than 1, okay? Last week, it was 1.13. So that's a little lower. That's going the right direction. What about testing? We look at percent positive tests. During the July spike, we had 22 to 25% test positivity. That's really high. Last week, it was a little over 14%. This week so far, it's around 13.5%, so it's a little bit lower. Last month, you can see it was 7.5%, and back in September and October, it was less than 5%. But nonetheless, it looks like it's either leveled off or going back down, which is good. Again, we have to see this sustained over at least 1 to 2 weeks, okay? But it looks like for the last 3 days, things are looking a little better. It's nowhere near the July numbers. We don't want to get there. What about new cases? Yesterday, which was the 13th, there were 3,200 new people reported positive in the greater Houston area. Last week, it was 61 cases per day. Again, still considerably up than last month, but nonetheless, it looks like there's a slight drop. And then if you look at number of patients being admitted to the hospital, that's a delayed indicator, and I'll show you why that's a delayed indicator in a moment. You can see that we admitted 328 new admissions to the TMC hospital institutions. So that's Memorial Hermann Healthcare System, that's Houston Methodist Healthcare System, CHI, Harris Health, okay? That's down from 335 hospitalizations per day. Again, still up considerably from the prior month, but you can see the direction for some of these key indicators are either leveling off or beginning to come back down. And I hope that that holds. And then if you look at vaccinations, which we're all looking at vaccinations, here's the number of doses that have been administered by TMC institutions. 40,000 have received 2 doses. Texas actually is outperforming California and New York by a long shot. Now, one of the challenges with vaccines is we've got a lot of doses that are out there, but only about 60% of the doses that have been distributed have actually gotten into people's arms. Now, we're getting better at it. There'll be some mega sites that will be coming up fairly soon, but actually Houston has done better than most large cities. Texas has done better than most large states, but we still can do better. Now, to give you some perspective on deaths at the beginning of this year, it's a little bit sobering. COVID now has just gone a little bit ahead of cardiac disease as a leading cause of death in the first week of this year. And you can see the cancer deaths and accidents. So it's a serious virus. Now, we know some of the risk factors for deaths. Probably the biggest risk factor that's not on here has to do with age. But if you've recently been treated for some blood or lymph node cancer, you've got poorly controlled diabetes, you're really obese, males are a little bit more susceptible than females. And you can see there is some African-American community, Hispanic community tends to be a little bit higher risk as well. And if you look at mortality rates, this is a little bit busy slide, but I want to show you something. Look at SARS, the original SARS. The overall mortality rate was 14 to 15%. That's really high. MERS is even higher. We now know that because COVID for all populations is less than 0.5%, and here it is for influenza, it's closer to around 0.2%. So there's no question that COVID is higher mortality than influenza. But compared to SARS and MERS, it's much less. But again, it's also more contagious. If you look by age, if you're under age 4 or 5, I will tell you, you're more likely to have a serious complications and death due to influenza than you are to COVID. As you begin to get older, especially if you get around that 60 to 64 and then 65 and older, you can see deaths. And that's why this is really the most significant risk factor is actually age. And you can see it certainly is higher than it is for influenza in this age group. But most of you know influenza has a higher death rate with age as well. Now, you all heard about this variant, so I want to kind of mention it. That's the B117 variant. Many of you may not know that very early in this pandemic in the United States, we went from this D SARS-CoV-2 to this G SARS-CoV-2. It turns out that the G form was also more contagious than the D form, but it wasn't more lethal. It wasn't more virulent. This new variant is very much like the G strain in that it also tends to be more contagious, estimated to be 50% more contagious. But again, there's no evidence that this strain is more virulent. There's a number of mutations that have occurred, but importantly, remember I talked about the spike protein. Importantly, there's only been a handful in the spike protein, and by most experts, the current vaccines being administered should continue to be effective even against this variant. So I think that's an important consideration. Also, you should mention that this now been seen in multiple states in 30 different countries. So how does this thing, why is the spike protein so important? I'm not going to get too basic science here, but the SARS-CoV-2 virus attaches to what's called H receptors by this spike protein. That's the only thing that I really want to show on this, which is why everyone's focused so much. Can we do something to neutralize that spike protein so it doesn't bind to these H2 receptors and therefore will not cause infection? Now, the clinical manifestations of this virus is absolutely fascinating. It involves almost every organ system in the body. There's nothing like this that I've ever seen. From your heart, you can get strokes, you lose your taste and your smell. Obviously, everyone knows about the lungs because that's generally what gets people into really life-threatening situations with pneumonia. You can get rashes. It can affect your blood counts, your ability to clot, and sometimes actually you overclot. And then one of the most common manifestations is actually whether or not you have nausea and diarrhea. So this involves almost every organ in the body. It's a fascinating virus. Now, the good news is, as I already mentioned, 40% of people are asymptomatic, and that's that top thing. But over 80% either have really mild illnesses. Of those that get hospitalized, they may have a slight drop and they need a little bit of oxygen support. And it's only that 15% that develop more severe illness and only 5% to develop critical illness where they get really bad pneumonia and they may have to be put on a ventilator. This is the group, unfortunately, that has the highest risk of dying, is the one critical. But you can see that the vast majority of people infected with this particular virus either have no symptoms or have mild symptoms. It's only that 5 to 15% that really require hospitalization. Now, I mentioned about hospitalization being the late indicator, so I want to kind of give you a little idea of what I meant by that. So remember, we told you the average incubation period is about 5 days, so you get infected here. Then you have the onset of symptoms, and again, multiple organs can be involved. The most common one's going to be fever and cough, fatigue. By the way, loss of taste and smell is very specific for this particular virus. And that, by the way, that means that it's involving your central nervous system. It's the so-called olfactory nerve, which is what's responsible for smell. So here you are getting symptoms now. You really don't get into trouble for about 1 week later when pneumonia sets in. So you get dyspnea means shortness of breath. And then you can see another 3 to 5 days later, the illness becomes more severe. So that's why I'm saying hospitalization is a delayed indicator, because it may mean 10 to 14 days after the exposure and the onset of infection. Now, I also want to emphasize on this slide, remember I talked about how the virus is up in your nose and throat before you become ill. And I want you to look at the amount of virus which is present. So here's there's no symptoms. So you can see that a couple of days before you develop symptoms, you still have a fair amount of virus that you have in your nose and throat. And you can see once symptoms begin, the amount of virus drops fairly quickly. So that in most studies, even in household contacts, by 6 to 8 days, transmission no longer occurs. So you have to have a certain amount of viral load present in order for transmission to occur. And that's why using a mask to block the amount of virus that gets into the air, and you also wearing a mask, which will block an additional virus, will cut down on the amount of virus that may get in contact with your nose and throat to either abort the infection or to not be infected at all. So I think that's just an important concept to keep in mind. Now, it also is felt that people who are symptomatic are more likely to spread the disease than those that are asymptomatic, but nonetheless, asymptomatic people can certainly spread it. Just a word about testing. You probably heard all this, and what kind of test should I get? The gold standard is still the PCR test. You probably heard there's a lot of rapid antigen tests, which is available in urgent centers and a lot of physician practices. The antigen test is a pretty good test if you have symptoms. If you don't have symptoms and you have a negative antigen test, you should go on and get a PCR test in addition. PCR still has a higher level of sensitivity compared to the antigen test. So just keep that in mind. The antigen test, there also are some false positives associated with the antigen test. So just keep that in mind, that if you're symptomatic and you have an antigen test which is positive, then you can pretty much bet that that's probably correct because it's got a high specificity. But if it's negative and you have symptoms, you should go on and get a PCR test, and you should not rely on the antigen test if you're asymptomatic. So that's the only point that I wanted to make with that. Now, I'm only going to say this very briefly. We're obviously looking for therapeutics that if you would, that penicillin, that we could knock out this virus before it can get people really, really sick. Unfortunately, we haven't got that. And I'm not going to go through the slide, but I just want to mention a few therapeutics which have become available, which even though we see increasing number of deaths because of increasing number of infections, the mortality rate, that is the number of people who die, who get infected, has actually come down because we now understand this disease process. You've probably all heard about remdesivir. If it's given early in the course, it's very helpful. Steroids, dexamethasone, for people who have lung involvement where they require oxygen, it's been shown to clearly decrease mortality. On the other side, we now have monoclonals, and where monoclonals are being used in our community is we get people who have early symptoms. They don't require hospitalization, but they may be in high-risk groups. We are using monoclonals as an outpatient to reduce the progression of the infection so they don't get into the moderate to severe disease category and require hospitalizations. We think that it's working. We've probably given a total of almost 2,000 courses over our community since monoclonals became available. So that's another therapeutic that we have in our toolkit. So we're learning better how to reduce progression and a little bit how to treat this disease, but it's not the magic bullet that we would like. Now, I'm a big guy in infection prevention and hospital epidemiology, so I believe the best form of treatment, in fact, is prevention. So one of the things I want you to take away from today's conversation is this particular Swiss cheese model. On the left-hand side, it talks about our personal responsibility. What do we do that can prevent transmission from occurring? They're pretty simple. Darn it, stay home when you're sick. When school reopened this January, there were students that were coming to class with symptoms. Some of these students were found to subsequently be found to be infected with COVID. Some of these classes had to be closed. I could not believe, after all the messaging that we have had, that parents would send children who are ill to school. The same thing at work. You don't come to work when you're ill, and you maintain your physical distance, hand hygiene, You know, really, really important. If you're coughing, you cover your cough. Stay away from touching your feet. Use masks. Universal masking should be the standard. It should be just the same as putting your seatbelt on when you get in your car to drive. Try avoid touching your face. It's amazing how many times you actually inadvertently touch your face. Stay away from crowds, folks. Even small gatherings outside your own household. That's how a lot of the transmission is occurring now, because of family gatherings during the holidays, COVID fatigue. I really understand it. We now have much better fast sensitive testing, which is really great. Another very important thing is improving ventilation. Do things more outdoors if you can. That's really important. I can tell you that Beth Israel has been outstanding in this. The facilities folks have done everything I've asked them by improving the amount of outside air exchanges, improving to medical filters in the building. Tremendous amount of stuff being done down at Schlenker. So they've been outstanding in trying to improve ventilation. Obviously, you quarantine and isolate when you get sick. And now we have the vaccine. And we hope that we can stop this transmission from occurring if we do all of these things well. And then the vaccine, of course, is our last backstop. Now, I'm going to say a few things about masking. By the way, I didn't realize this, that if you go back to the literature and look at 1918, they were anti-maskers back in the pandemic of 1918. But look at that, wear a mask or go to jail. You know how well that goes over in certain communities. There's a couple of different masks you can use. The old level 1 surgical mask, which you can buy anywhere now, is really, really good. You do not need to wear an N95 mask unless you're working in the hospital doing certain procedures that generate aerosols, like putting someone on a ventilator, nebulizing treatments, etc. But just a good mask is really helpful. And this is a really nice study for you to take home. These alligator one-layer masks, they're worthless. Look what happens when you sneeze in terms of the number of droplets compared to no mask. Doesn't do very much. Now, the good 2-cloth masks, you can see do much, much better. Just a little bit here. And you can see the surgical masks are one level better. So at least a 2-ply, highly woven mask. And again, the whole purpose of universal masking is to prevent those aerosols. So here's the index case. You're outdoors, okay? But you don't think outdoors is safe. However, this index case has virus. You can see what happens. It comes in contact with your nose and throat, potentially your eyes, and guess what? It gets into your lungs and you get sick. Where if the index case is wearing a mask, you can see the droplets don't go very far. And then you have another protection in the fact you have a mask on as well. Transmission generally does not occur. And I'll show you a study about that in just a moment right here. This is a great study. So as you know, the hairstylists were shut down for a while. Some of us had to let our hair grow a little bit longer than we wanted to. And they finally allowed hairstylists to continue to come back to work. And here's a great example of how universal masking works. There were 2 hairstylists that actually had symptoms, came to work, found to have COVID. As you know, hairdressers are within 1 foot to 2 feet of you for over 15 minutes. These 2 hairstylists had 139 clients while they had symptoms. But of course, the client also wore a mask. And when they followed up on these people, none of the clients got infected with COVID. So that's why universal masking is so very, very important. The other thing I want to emphasize on this slide, on the right-hand side, it turns out, because this is a big controversy about opening our schools, more and more data has come in that schools who have good mitigation, that is safety things in place, social distancing, masking, hand hygiene, good ventilation, okay, that's not where transmission is occurring. It's not occurring in the classroom. You know where it's occurring? It's occurring when the kids go out and they have parties and they have play dates and they have small gatherings. It's occurring in the community. The other good thing we've learned is that in fact, transmission to teachers doesn't appear to occur very often in the classroom either. So one of the messages for our students is, hey, we got you covered while you're here at school, but you've got to do your job after you leave here. And so partings and play dates and small gatherings, both for adults and for children, have the capability for transmission. That's where most of our transmission is occurring. Now, I'm going to end our conversation with what I know you all want to hear about, right? And that's vaccinations. Okay, so I kind of like this cartoon. It says vaccines should be tested on politicians first. If they survive, the vaccine's safe. And if they don't, then the country is safe. And boy, I can pull my hair out about the politics that are going on in Washington, D.C. and beyond. Now, one of the guiding principles that the CDC used and the ACIP, which is the group that advises the CDC on immunization practices, is they want to maximize the benefits. And here's some things that is important to keep in mind. They wanted to promote justice. And those of us, this is bread and butter to us in Judaism. Social justice and promoting justice and mitigating inequities is so important to the culture of our religion. They want to know if the allegation plan is fair and equitable across all the vaccines for all groups. Now, I want you to think about this for a moment. I happen to know of a high rise in which there's a fair number of Jewish people living in that high rise. And do you know, they had a pharmacy come into the high rise and provide vaccinations for them. Now, do you think that happens in the Gulfton area where there's a huge Hispanic community with lots of high-risk people? I don't think so. So trying to mitigate health inequities is really important so that we can get vaccinations to other groups who are disproportionately affected by COVID. So those of you who haven't been vaccinated understand, first of all, we don't have enough vaccine yet. But secondly, we're trying to balance justice and inequities and making sure people who need the vaccine, who have barriers to vaccination, can get access to the vaccine. So keep that in mind. Now, I'm not going to go in too much detail. I'm going to mention 4 vaccines. 2 that you already know a lot about, the Moderna and the Pfizer vaccines, which are both being administered now in the United States. And there's one really exciting vaccine that I'm excited about it's coming from Johnson Pharmaceutical, which is a subsidiary of Johnson & Johnson. And I'll show you what a viral vector vaccine means compared to a messenger RNA vaccine. But this vaccine is only 1 dose, and at least phase 1 and phase 2 trials, that looks to be as good as 2 doses of Pfizer and Moderna. What we need, of course, is the result of the phase 3 trial to see if it has the same protective efficacy that Pfizer and Moderna vaccine. 95% efficacy. That's absolutely incredible. In a good year, influenza may be 60 to 65%. And we have these 2 new vaccines, which are the so-called messenger RNA, which I'll explain in a moment, has 95%. Now, you've probably also heard about the AstraZeneca vaccine, which has been approved in the UK and is being used widely. That's a 2-dose, also a viral vector vaccine. And then there's another vaccine by Novavax, which is a very interesting protein vaccine. Those trials are now starting again, and that also has the ability. If looking at a timetable, Moderna and Pfizer are available. I think J&J and AstraZeneca hopefully will have their results of their phase 3 trials, and will be able to present this to the FDA the end of this month or the beginning of February. And we may have 1 or more additional vaccines. The good thing about J&J's vaccine, it doesn't need cold storage, and it's less expensive to manufacture, and it only requires 1 dose. It could really be a game changer in the vaccine front. So let me show you how these vaccines work. The current vaccines, the RNA vaccine, it's just, to me, the technology is amazing. What they do is they take the gene from the virus, not the whole virus, but the gene that codes for this spike protein. They embed that in this cellophane kind of protective envelope. It gets injected into the body. The cell processes that. The genetic material makes the viral protein, that spike protein. It's a very broad responds to the spike protein. That's why 1 or 2 mutations is unlikely to do away with the protection of the vaccine. And then you get a wonderful immune response, okay? Now the vector ones, which are in these harmless other viruses called adenovirus, which do not replicate, okay? They also carry that gene. It gets into the cell through messenger RNA. They develop the viral proteins and again, the immune response. So that's how these vaccines work. It's just fascinating technology. So here's the 2 vaccines that are available. Both of them require 2 doses, one 21 days apart, one 28 days. You can see the protection here is 95%, just absolutely amazing. And by the way, age is not a determinant, but how well you respond to the vaccine. This is wonderful. So if you're over age 65, you're going to respond to this vaccine as well as someone who's 50. Now, there's the breakdown: male, female, African-American, Latino. You can see all ages, all ethnicities respond to these vaccines. That's amazing. With influenza, we have to use a high-dose influenza vaccine to get a good response in the elderly. And here are the side effect profile. Most people who take the vaccine, and I obviously got my 2nd dose, they're going to feel fatigued and some joint aches and maybe some low-grade fevers. That occurs in 25+%. It doesn't last very long. There's a rare person who's gotten this anaphylaxis. We think that's maybe due to the propylene ethyl glycol that's in the vaccine. But there's only been 29 cases despite millions of doses. The timetable here, I put in bold. It's uncertain. And I mean, it's uncertain. However, it's really going to rapidly improve. And at the bottom here, they've gotten about 28 million doses distributed. But look at this. Only 9.3 million have actually been administered. So even though the Biden vaccine, administration wants to release vaccines that are being held out for people to get their 2nd dose, and I think that's reasonable to do most of it, but I would still hold some back in case there's some manufacturing problems. But even if we double the amount of vaccine available, which by the way will occur, okay, we still got to get it into people's arms. So we've really got to figure out a way to do that well. And one of the other things is vaccine hesitancy is 20% of healthcare workers that don't want to take the vaccine. It's gotten better, as you can see by this survey, from September to December, but there's still people who won't take the vaccine. That means it's going to take us longer to get the herd immunity. Now, what would happen? So if we had a reproductive number 1.5, we had 2.25, and you look at the differences in mortality. So the mortality for most places is around 0.5%. We have transmission over 3 months. Look at the number of deaths. The question I ask people for vaccination: would you rather be in the right-hand column, or would you rather be vaccinated and not be part of that 300,000 infections that may occur without vaccine? I think the answer to that's pretty obvious. So we've got to improve vaccine acceptance. How do we do that? We got to promote public trust about the efficacy and safety. We've got to do this through community engagement. Messaging nationally is great, but all things are local. We've got to identify trusted leaders with consistent messaging based on science, not based on fear or hyperbole. We've got to remove the practical barriers, especially getting into those underserved community. And I think it's a moral obligation for us to get vaccinated. It's more than just about us. Damn it, it's about our community. We want to promote the health of our community and stop this pandemic. We can't do it. We can't do it unless it takes all of us to do that by maintaining social distancing, wearing our masks, and getting vaccinated. We've got to do this. These are the vaccine priorities that are seen here. We're now in 1B, and now actually we've slipped into 1C in Houston, 65 and up. And now we're getting to those people with certain underlying health problems, which I mentioned: essential workers, people who work, obviously, teachers, public transit, fire and police, et cetera. And to give you an idea of the numbers, so how many vaccine we might have got. So here's healthcare personnel. We're the smallest group. Essential workers, depending upon how you define it, okay, might be another 80 million. There's some overlap here, okay? Over age 65 is about 53 million. And then other people with high risk. So if you put all this together, we need to get these vaccines in the arms of over 100 million Americans to really blunt the mortality rates so that younger people fortunately tolerate this pretty well with extremely low morbidity and mortality. But if we can protect our most vulnerable, we can learn to live with this just like we do with influenza. So if you do get vaccinated, by the way, there's a few things we don't know. We don't know, first of all, whether or not it protects you from infection. We know it protects you from getting sick, but you still could get asymptomatic infection, and that possibly could be transmitted to somebody else. So until we know that, we're still going to maintain all the recommendations at the bottom of the slide that we've been emphasizing throughout today. Now, when more vaccine becomes available, we can start vaccinating the entire population. I hope we get there sooner rather than later, especially if vaccines like the Johnson & Johnson vaccine come on board. And hopefully by April, no later than May, anybody who wants the vaccine can get the vaccine. I've already mentioned this. I also want to mention the other side about the medical unintended consequences this pandemic has brought. Immunization rates have gone down. Preventive care is not taking place, especially those people who have chronic disease, which has resulted, by the way, in people coming in sicker and having a higher risk of dying. We see increased domestic violence, mental illness, and depression. By the way, this occurs in our children as well as our elderly that may feel very isolated during this pandemic. We've seen opioid use go up, and we've seen alcohol use go up as well as we're stuck at home, and people have either postponed preventive care or have postponed treatment for cancer. And so we see many, many cancers having increasing morbidity and mortality. I'm going to emphasize contagiousness is more a function of behavior. Get vaccinated and follow those 3 W's. Here's how we slow the pandemic. I've mentioned all of these things before. And here's the way we can live with this virus. Universal masking avoids crowds, social distancing, even small gatherings have the potential for transmission. Yes, outdoors is better, but if you can't maintain social distancing, you should still wear a mask. And of course, wash your hands and disinfect the environment. So I want to sort of end on this very cute, if I can get this to work, video. Okay, here we go, guys. What do you think? It's up to us, folks. I want to end, since this is obviously a Jewish adult ed, on an excerpt from Rabbi Weinberg. Every life, every day, every hour is a journey. In the travel, it is a discovery. The wisdom, and by the way, there's joy that comes out of the wisdom. In every life, every day, every hour is a journey. In the travel is the reward, the peace, and the blessing. I wish that to all of you. And now we'll end the presentation, and we'll take any questions that are in the chat box. But I hope the time we spent together this evening gives you hope that we really are at the point now we're beginning to turn the corner, and that we can really begin to think about a new way of living, but hang on for 2 or 3 more months. Okay.
Thank you, Ed. That was really, really exceptional and very helpful. And I really thank you on behalf of all of us, and others will have their other comments if they have some. But throughout the presentation, we did get several questions in the chat that I'm just organizing into 2 major areas. One is about the level of contagion and how contagious the virus is, especially the Brazil variant and the UK variant. And so what are if there's any other information you have about the variants and what we need to be aware of other than what you said? And also, are there any conditions that a person might have which would make them less susceptible? Is there a particular immunity that they are naturally born with Can you speak to both of those areas as it relates to how contagious the virus is?
Well, I think I pretty much talked about the contagiousness of this new variant, and it's quite possible we're going to see it become more and more predominant in the United States, which is why it's so important for us to maintain the 3 Ws and to get vaccinated, so we can blunt that potential for increasing transmission. The other strain, though, that some people sometimes make is the South African strain, not actually the Brazilian strain. So we're going to be monitoring that very carefully. As I said, it's now in at least, I think, 12 states in the US and in 30 countries. I actually, I have to take a chuckle, by the way, about the fact that in 2 weeks, we're going to start requiring people traveling from overseas into this country to have a negative test. Did you all read that in the paper? In 2 weeks. And I'm thinking to myself, if it's that urgent to stop this variant, why are we waiting 2 weeks? You know, that statement by that local expert saying we failed to block transmission, this variant is probably already here. We don't have the genomic testing that the UK does. And by the way, there's nothing that says, what about if I've been immunized? Seems to me that if I can show proof of immunization, that should be at least a substitute for testing, because testing to admit I could test positively negative today, and tomorrow I can be tested positive. So it may have some effect, but I still think vaccinations are really the way to go. And what was the second part of that question, David?
It was more about whether there's anything that can make us less susceptible to getting the virus.
There's some thoughts that certain blood types may be less susceptible to the virus. On the other side, low vitamin D levels may make the virus more severe in terms of the other side. And then little children seem to have a lower infection rate than older children. Now, part of the reason it's felt is there are a lot of the common cold viruses, other coronaviruses. And it's felt that since they get so many colds before age 4, compared to adults that don't get as many colds, that there may be some cross immunity between other coronavirus, but the problem is it's somewhat short-lived. So maybe that's why younger children, one of the reasons why younger children are not infected at the same rate, but maybe certain blood types, maybe, but in terms of protection, but otherwise, those other high-risk conditions are what makes people more susceptible as opposed to less susceptible.
Thank you. A couple questions on the vaccine. There's been discussion about, and you mentioned the second dosage, and have you heard anything about what we might expect to have happen as it relates to both doses, whether we're going to have the second dose that's not going to be used, or that's going to be used for people to get the first dose, and whether there's going to be enough available for the second dose? You touched on that, but can you elaborate on that more? And also, will it be necessary to be vaccinated annually? Do we know how long the vaccine will last? What can you tell us about that issue?
Great questions. First of all, as I already mentioned earlier, half the doses have been held back so that there's going to be a second dose for anyone who gets the first dose. That's probably not going to be the case much longer. We have a fairly good, reliable manufacturing process in place and many more doses on the way. So we're going to release more of those doses so we can get more people immunized faster. I'm not concerned at this point in terms of that supply chain for vaccine. Now, the other question is a good question. How long are these vaccines going to be good for? So there's a couple of different ways to look at immunity. One is the antibody levels to that spike protein that I talked about. The other one is what we call memory cells, especially B cell, which actually produce antibodies. And these vaccines, the two messenger RNA vaccine, Moderna and Pfizer, and also the J&J vaccine, which I just mentioned earlier, all not only give you antibodies, but they also stimulate memory cells. Now, the reason I say that's so important, that even if your antibody level begins to come down, if you're re-challenged with the virus, you have memory. And so that hopefully you'll rapidly get those antibody levels up and either prevent you from getting infection in the first place or abort the infection before it can cause symptoms. So that's the thing. Now, how long the immunity, we think studies are looking at least 6 to 9 months and maybe even years. But to be honest, remember I told you, I'm only going to tell you what I know, not what I don't know. We don't know how long could it be that every 1 to 2 years, or if there's a significant mutation in the spike protein, that we may need to be immunized in every 1 to 2 years, the way we do for influenza? We don't know that yet, but we hope that this vaccine will give us, at least a year or more, but we're just not going to know until we've had more experience. But nonetheless, it gives you great immunity, both the antibodies and the memory cells, and that's one of the important aspects of these vaccines.
I think we have time for one more question, which I see in the chat that Larry Burnell has asked, and that is the big question. If we haven't yet gotten our vaccines, how do we do this? How do we get our vaccines? How can we go about this process?
Well, that's a great question, Larry. If you are associated with a major healthcare system, so if you're in the Memorial Hermann network, or you are in the Houston Methodist network, they've got your name and they know how old you are, and they will be sending out invitations for you to sign up and get an appointment to get the vaccine. If you're outside some of those big networks, there will be mega sites being set up very shortly at Reliance Center and other sports venues that will be manned by the city health department, by Houston Methodist, by Memorial Hermann. And so fairly shortly, and then pharmacies, by the way, will begin to get the vaccines. One of the things about the Moderna vaccine, although it does require freezing, it doesn't require the ultra cold freezing that the Pfizer vaccine. So the Pfizer vaccine has pretty much been reserved to the large healthcare systems, and Moderna has been the ones that's been used even at some of the Houston Methodist sites and Memorial Hermann sites in the clinic setting, where they don't have the cold storage capabilities. So I think if you haven't gotten it yet, get onto the city site, get onto Memorial Hermann, get onto Houston Methodist, and when these vaccines become available, you certainly are eligible now if you're over age 65. Sign up for one of those slots, but I think in the next couple of weeks, you'll see much wider availability of vaccine, and I hope eventually that some of the pharmacies will be able to offer it as well. So it's easy for me to say to be patient, but I can tell you, we've done a good job in this community. I like it better. I'd like to see more people getting shots in the arm. We still have doses that have not been given, but we've done a pretty good job. If you heard the news from New York City, they've wasted doses. Once that thing comes out of the ultra cold freezer and it gets put in the refrigerator, you only have a certain amount of time in which to use that vaccine, or else you have to throw it away. So be patient. Those of you who are in the high-risk group, especially the elderly, you should be able to get an appointment for a vaccine within hopefully the next couple of weeks.
That's fantastic. Thank you so much, Ed. We really do appreciate it on behalf of all of us. So grateful for your presentation. Friends, if there's something you missed in all of the science and all of the explanation that Ed gave us, we did record this session. It will be made available for you and anybody else who you think would benefit from hearing it through the Temple website. So please look out for that in the next day or so. We'll have it posted online. Also, I hope to see all of you tomorrow evening for our MLK Shabbat experience at 5:30. There's the Zoom service first that Rabbi Scott will be leading. At 6:30 is the event itself, which will be live streamed through the website and social media. And then after that, about 7:15, 7:20, we'll have an Oneg online so that you can collaborate and share and wish each other Shabbat Shalom with the clergy. Next week, Wednesday evening at 7 o'clock, Rabbi Lyon will be doing a first of two parts on the prophetic voices of Judaism and learning more about the prophets. And that's a 2-week session on this coming Wednesday and the following Wednesday. And Thursday afternoon at 12, this coming next week, Dr. Victoria Ahrens from Trinity University will also be sharing with us her expertise on Holocaust literature in particular, as we think about and reflect on MLK and International Holocaust Memorial Day as well. So a lot to look forward to in the coming weeks, and we look forward to welcome you to it. So thank you very much for coming, everybody.
Thank you. Appreciate it.
Thank you.
Thank
Bye, everybody.
you.
Stay safe.
Ed, can I
Yeah.
ask you a question?